David Campbell from University of Adelaide, South Australia, and I'm speaking to you about our JBJS article, 15-year mortality following periprosthetic joint infection in total knee arthroplasty. My colleagues and I have used data from the Australian National Registry to describe the association of mortality with knee revisions for PJI. With registry data, we can examine very large numbers of revisions with virtually complete data capture over decades. And these findings complement the information derived from specialised revision centres because it captures the entire country and reflects real-life practice of PJI. We reported 870,000 primary knee arthroplasties, including 35,000 revisions, of which 8,500 were revisions for PJI. The findings were both disturbing and predictable. Primaries and aseptic revisions had a very similar mortality throughout the study and had a survival advantage compared to the matched population. Conversely, PJI revisions were associated with dramatically worse mortality. During the first year, revision for PJI had a 6 times greater mortality compared to aseptic revisions, and it remained increased past 18 years. When we compared the standardised mortality, which is the observed mortality compared to the age and sex matched mortality, there was an overall mortality risk of 33% for the duration of the study, and this was most apparent in younger patients who had twice the expected mortality. When we analysed risk, there was no surprise that older patients were up to 9 times greater risk than younger patients. Increased ASA had 2.5 times greater risk. There was also an increased risk for underweight patients and those with class 3 or greater BMI. A surprising finding was the observation that patients who had minor revisions compared to major revisions had a greater mortality for the first 18 months despite the less morbid surgery. For clinicians, we have provided a number of tables in the paper that may be useful for counselling patients. Especially for an elderly patient, their lifespan is severely decreased. For example, a patient aged 75 or more has a 10-year survival less than 40%, and the chance of living to 90 is less than 15%. Perhaps for these patients, our goal should be quality of life more than cure. Conversely, younger patients have deteriorating mortality over time, and we did not observe worse mortality with major revisions, suggesting cure would be the priority for the younger patients. This study highlights the dreadful mortality associated with PJI revisions, and it should be a stimulus to fund more studies on management and prevention of PJI.